our two presenters on engaging best practice champions in pain assessment and management. Now, first we have Carrie Burley, and she obtained a Bachelor of Science in Social Work in 2003 from Miami University in Oxford, Ohio. And she worked as a social worker in long-term care since 2004 in the States as well as in Canada. And then in June of 2020, she took on the role of administrator at Mackenzie Health Long-Term Care Home. And she has a passion for providing resident-centered palliative approach to care for all residents in long-term care. She did complete the LEAM long-term care course in 2017, as well as participated in the Ideas Project for Palliative Care and Long-Term Care in 2018. She's currently working on completing her master's degree in social work at York University and will graduate in June 2022. We also have Clara Nissan, and Clara received her RN diploma from the Kaplan School of Nursing in 1979 and her Bachelor of Science in Nursing from Ryerson Polytechnic University in 1998. And in 2004, Clara received her Master of Nursing, the Nursing Administration from the University of Toronto. And in 2014, she completed her Primary Healthcare Nurse Practitioner program at Ryerson University. She is a knowledgeable and resourceful primary healthcare nurse practitioner with 25 years of experience. She is acknowledged for possessing a combination of strong clinical leadership and analytical skills, along with strong communication and networking, allowing for troubleshooting and problem solving. She has demonstrated ability to support residents and their families, nurses, the interprofessional team members, managers, and contributes in team initiatives. She has strong organizational and project management skills for ensuring ongoing improvement of care. And at present, she's working at Mackenzie Health Long-Term Care as a Director of Care Clinical Services and the Nurse Practitioner and Best Practice Spotlight Organization, or BPSO liaison. And now, without further ado, I'm going to pass it on to Carrie and Clara. Welcome.
Thank you very much for that introduction, and thank you to the RNAO for inviting Clara and myself to speak today. We are so excited to share our knowledge and experience regarding the assessment and management of pain here at Mackenzie Health Long-Term Care. During this presentation, participants will gain a better understanding of strategies used by Mackenzie Long-Term Care in implementing the assessment and management of pain best practice guideline. We will highlight strategies that led to successfully recruit and engage all interprofessional team members and quality pain best practice champions, to identify the relation of implementing the pain BPG recommendations with improving and sustaining residents' quality of life, to learn how to implement and use pain assessment tools, to use best practices for ongoing quality improvement in pain management, and how to effectively monitor and audit pain management in the home. Just a quick overview of our facility here. It is located in Richmond Hill, Ontario. We have two units, a long-term care unit and an interim bed unit. Our long-term care unit has 136 beds and the interim unit has 34 beds. We are also unique in that we have capacity to care for 30 residents who receive hemodialysis treatment, and we are one of two specialized units in Ontario. Our palliative care program is a formalized program, and we have the skills and ability to care for residents receiving the palliative level of care. We can look after around 20 to 30 residents at a time. Moving on to our exciting launch of our Best Practice Spotlight Organization project. We launched in July 21st of 2020, and we had a successful event, which really got our team excited to begin the process. This slide shows our steering committee. It is our organizational chart. It is comprised of a diverse interprofessional team, such as nurse practitioner, registered nurses, RPNs, PSWs, and social work. And we all work together on our best practice guidelines. Our team put together a group of registered staff who were designated quality indicator champions for pain management. This team works a full paid day once a month to audit and assess pain outcomes. This ultimately works towards high quality resident care for pain management in our home. This is a pilot project, which is called our Intentional Hourly Rounding Checklist, and it was an effort to improve our pain management in the home. It was a 3-month pilot project that allowed our interprofessional team to assess our residents on an hourly basis for pain and other unmet needs. We were able to successfully implement this using a paper format. And once we were able to determine that it was a successful way to manage our residents' pain, we were then able to implement this electronically. We were further able to then purchase iPads for the ease of documentation for our staff. This is an example of how we disseminate information about our pain BPG in the facility. We created a pamphlet that is available for all staff and residents and families to familiarize themselves with our pain program. So now we will spend some time reviewing the different definitions of pain. So what is pain? It is the most widely used definition of pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. It's important to note that pain is a complex phenomenon that impacts an individual's psychosocial and physical functioning, which is why our team is very interested in maintaining an interprofessional approach to pain management in our home. When we're talking about pain, it's important to understand the pain triad. And the pain triad takes a look at the biological, psychological, and social factors that influence pain in an individual. A form of chronic pain that is also seen in long-term care. So chronic pain is something that lasts or recurs for more than 3 months. And chronic pain can also be considered an invisible epidemic. Chronic pain affects 1 in 5 Canadians. Opioids are often prescribed for chronic pain. And of those addicted to opioids, 4 out of 5 individuals start with a legal prescription. It's also important to note that opioid-related deaths are on the incline in Canada. And you can see the statistics below ranging from 2016 to 2018. So chronic pain is defined as something that is a pain that is experienced by an individual for a minimum of 3 months. But there's also virtually no studies for chronic opioid use. And there's no evidence for the benefit of opioids in long-term management of chronic pain. So observational studies show that prescribed long-term opioids for chronic pain is associated with an increased risk of abuse, overdose, fractures, and heart attack. Yet the studies show that pain intensity is largely unchanged after the discontinuation of long-term opioid use. In a recent study of 96 random controlled trials show that opioids offer little benefit and often wane over time. So what is the impact of chronic pain compared to pain-free older adults? There's an increase in disability and frailty. There's an increase in sleep disturbance and malnutrition. There's an increase in depression, distress, and suicidal ideation. There's a decrease in social functioning and an increase in healthcare utilization. So what is the prevalence of pain in the geriatric population? Here are some statistics to consider. There's a prevalence of chronic pain as the age increases. 65% it is seen in 65% of community dwelling seniors, in 80% of long-term care residents, and pain is often under-recognized and undertreated in the elderly. Chronic pain is associated with the worst quality of life as compared to other chronic diseases, such as lung disease or heart disease. It's also important to note that 1/4 to 3/4 of older adults suffer from chronic pain, which will have an impact on their mobility and dexterity. There's a higher prevalence of chronic pain that skews towards institutions, and the most commonly used medication to treat chronic pain are opioids. It's also interesting to note that 66% of seniors take at least 5 medications, so polypharmacy is definitely something to consider in this population.
So to continue with prevalence of pain in the geriatric population, for seniors in long-term care, the prescriptions number rises to where more than 60% take 10 or more medication, a number of which may be treated symptoms relating to this chronic pain triad, such as opioids, benzodiazepines, antidepressants, and antipsychotic, use 2, 3, and 9 times rate, respectively, of those living in the community. The prescription overwhelmingly sedating, increasing risk of delirium, fractures, falls, PEs, CVAs, and budgets. So Mackenzie Health long-term care uses computerized assessment and documentation for pain assessment and management. Screening done during med passes, hourly rounding, any interprofessional provision of care, such as before and during and after procedure. Example, change of dressing, ambulation, passive or active range of motion or exercise. Pain assessment, symptom assessment is done with OPQR-STUV, which stands for onset, provoking, radiating, quality, severity scale, treatment timing, understanding the impact and values, goals of care. This assessment can be done for residents who are cognitively intact and aware residents who are able to communicate. As we know, many of our assessments are done to people who has advanced dementia and not able to communicate. The assessments that we are using, it's pain aid for cognitively impaired patient. The assessment done within 24 hours of admission or readmission, quarterly and annually, according to the RAI MDS schedule, as well with significant change in health status or pains that are not relieved from initial intervention. When the pain management strategies are no longer effective or level of pain continues to be at 4 or above on NRS, numerical rating scale. So here we can see Passera for opioids assessment, and it's done every shift for 7 days. I just wanted to share our data with that comes from MDS RAI. And here you can see people who have pain. We are in blue and we are doing much better than provincial average. So our population, 95% uses pain medication and don't report pain. Next, you can see worsening of pain as well. We have here graph in green, in blue. This is us, Mackenzie Health long-term care, and we are much below provincial average. With this project, is also using antipsychotic medication without diagnosis. So again, our mandate to decrease the antipsychotic medication use without diagnosis. And we can see on this slide that we work very hard to reduce the number and we gain below provincial average. Interprofessional approach to pain chronic pain is best treated through interprofessional therapies, multimodal approach to pain management, physical therapies, occupational therapies, speech-language pathology, psychotherapy, spiritual care, lifestyle management, interventional therapy. We also develop realistic goal to reduce the suffering of pain. Challenges of pain assessment in the geriatric population. Inadequate pain assessment is the major barrier to adequate pain management. Sensory cognitive impairments, underreporting, myths that having pain is a normal part of aging, comorbidities complicating the clinical picture, lack of concurrence between patient and caregiver perception of pain. Caregiver may misinterpret their pain perception. The elderly may choose to suffer in silence due to a culturally oriented response to pain. Pain assessment in patient with dementia, self-report on reports from caregiver on family member, pain aid scale, pain assessment in non-verbal patients, non-verbal vocal complaints like gasps, moaning, screaming, crying, non-verbal indicators, facial expression, grimacing, winching, bracing, clutching or holding to furniture equipment, body language, protective behavior, body positioning, rubbing, massaging affected area, restlessness, behavioral changes, eating, sleeping, social. Non-pharmacological treatment. Non-pharmacological method should not be used as substitute for pharmacological management, should be combined with pharmacological management and methods to optimize pain management in the elderly. Heat, massage, Montessori approaches used by therapeutic recreation, such as forms of distraction via visual, auditory, tactile, and intellectual management methods. Effective pain management is dependent upon accurate assessment of pain and the development of holistic approach to pain that includes non-pharmacological and pharmacological method of treatment. In our facility, we started 4 years ago to work with cannabis, medical cannabis, and we had great success. Till now, we had approximately 60 residents who benefits from cannabis use. Why cannabis in geriatric population? When traditional treatments have failed and looking for better quality of life in collaboration with residents and their family during special care conferences. Key consideration will be polypharmacies, multiple comorbidities, reduce liver and kidney function, increase sensitivity to adverse event. Chronic pain, neuropathic pain, anxiety, poor appetite, decrease in antipsychotic medication with no appropriate diagnosis, as well as decrease of use of opiates. What we are considering when we're using cannabis. Cannabis use in increasing in elderly population. There is a lack of clear guidance regarding how to use and how to prescribe. We are starting very low and going very slow approach. Anecdotal outcomes are positive in our long-term facility. Interprofessional holistic approach, again, physician, nurse practitioner, social worker, PSWs, family and residents, all involved in this project. Pain best practice guideline outcome, as we said, as Gary mentioned, intentional hourly rounding pilot study that completed. Pain policy was revised to support evidence-based practices, has been introduced to the staff, 4Ps for screening for pain. Hourly rounding started in 2020 in August. Paper for form for hourly rounding completed. With success, it was 2 months pilot study. During this time, staff became knowledgeable with the process. We transitioned the intentional hourly to POCs, computerized, and purchased iPads for all our PSW for documentation efficiency. Preparation of 3 BPSO paint binders on each floor, printed brochures, printed papers, form, and then iPads. The forum introduced for 2 weeks education. We have ongoing education externally and internally for pain management. Pain assessment practices, every nurse providing analgesics to the resident, documenting efficacy of pain management via pain scale, NRS numerical rating scale. Reports from nursing register staff working in collaboration with the pharmacy. RIMDS team review the pain medication following the MDS assessment, including the quality indicator as well as outcome scales. Team to schedule and review on monthly and quarterly basis, and with significant change, use pain assessment OPQRST UV for verbal cognitively resident in PCC is point click. Use Pen 8 assessment for residents then non-verbal and cognitively impaired. Use Passera for opioid-induced. Tracking, reporting trends, outcomes, MDS quality indicator for pain and worsening pain, monthly audit for pain management in collaboration with pharmacy by designated quality pain champions, monthly audits for opioid use and query indicators, and reporting. Dissemination pain brochure was provided to resident, family, and staff. PAC meeting for physicians, staff education on an ongoing basis. So thank you for listening to us. And we want to leave you with the quote from RNAO 2007, effective pain management is dependent upon accurate assessment of pain and the development of holistic approach to pain that includes non-pharmacological and pharmacological method for treatment. Thank you. And if you have any question, please ask.
Thank you very much, Clara and Carrie, for that excellent presentation. And I really do believe, based on your presentation, that Mackenzie Health has embodied the holistic approach to pain, doing a holistic assessment of pain, as well as using the interprofessional team to be able to provide the non-pharmacological as well as the pharmacological treatments for pain. So thank you so much for that presentation. Well, we do now have time for questions, so please feel free to type it in the chat box and to indicate all panelists and attendees when you do so. There is a question here, and I'll start with this one. It says, cannabis is amazing, but it can also be expensive. Can you speak more about the cost?
Okay, so we both can sort of answer. So with the cost, it's always a choice for the resident and the families. It's offered as an option. And we do work with a company that does offer a discount. Should they be able to show their income, they will get a reduction in the cost. But again, it's never something that is pressed upon them. It's just presented as an option. And of course, we let them know of the website and they can review the costs on their own.
And as you said, it's really a challenge with the cost, really a challenge, because we had few residents who had very successful stories with cannabis, but were not able to continue with them because approximately $80 a month, it's expensive for our residents. You're absolutely right.
Okay, well, thank you so much. And just in follow-up to that, or is there any, just by chance, reimbursement programs or anything like that to help offset the cost?
Not that we're aware of.
Okay, that was just a curiosity on my part. Thank you so much. So please feel free to type in any questions. I do have some other questions here. Can you briefly explore current alternatives to opioids, which may be trialed for pain in the geriatric population? And that question's from Diana Snow, and she's an RN.
So this is what was our approach. And we had, again, successful story when we used the cannabis to taper very slow the opioids. We had one very successful approach to lady who was addicted since 17 years old to narcotics, and she used it quite amount of narcotics. So we went very slowly. We explained to the family, explained to the resident that we can start on a combination of THC and CBD oils, and to go very slow with this resident. At the end, the resident, we were successful to taper her almost everything. All the hydromorphine was tapered with cannabis oil, and fentanyl was just 25 milligrams from 75 milligrams. So it was really a success story.
That's amazing. Thank you so much for sharing. Wow. Okay, so, and Crystal wanted to add here, cannabis is a medical expense deductible on personal income tax. So that was just a follow-up comment in regard to the first question. And Amy is also asking, can you please speak to overcoming the fear and stigma regarding cannabis and opioids in the geriatric population? And any tips when discussing this with family and the clients?
Sure, I can answer that. Surprisingly, or maybe not surprisingly, there has never been a situation, maybe one time in the years that Clara has been prescribing, that someone was against it altogether for whatever stereotypes they may come with or preconceived notions they come with. Everyone was open to it, family and resident alike. At times we have new residents that come to us already prescribed cannabis from the community, or they're asking, how can you help me use this as a treatment? So like I said, surprisingly or not, really that has not been an issue for our experience.
And for families who can afford, they're really, really happy to start, because we are tapering completely antipsychotic medication, you know, especially for responsive behavior, poor appetite, neuropathic pain. Another story, success stories that we had, it's a resident after ophthalmic shingles who had terrible neuropathic pain, and nothing, you know, could help her, except when we started the cannabis oil, she was very quiet and the same, you know, and free of pain. So the family really asking us to continue with this oil, even though it's monthly expense, but they saw how helpful it was for this lady.
Oh, that's fantastic. I'm glad she was able to get some relief. There is another question here, again about cannabis. How about the use of synthetic man-made forms of cannabis, such as nabalone? Did you have any results on this? Because Regency Park nurses are saying that they think it's covered by OHIP.
Nabalone is covered by OHIP. I have one of my younger resident using Nabalone because he cannot afford cannabis, that he want to use it, but he's not able to do it. I order again, very slow tapering him. Maximum from Nabalone is given 2 milligrams, but we didn't have the same result.
Okay.
And I used for him cannabis and Nabalone, so I can compare.
Okay. No problem. Well, thank you so much for filling us in. There's also some other questions here, and you had talked about an interprofessional approach to engaging in the implementation of these best practices when it comes to the holistic assessment as well as management of pain. What are some of the creative ways that your home has encouraged staff to participate in the implementation of this BPG?
Well, in our home with our team members, we are always wanting to encourage our staff to build their own capacities. And so we presented this as a way of contributing to their own knowledge, as well as building a better quality of life for our residents and supporting our families. So Like we had, like I mentioned in the presentation, we had a really nice COVID-friendly launch party and lots of signage around the home and banners. And anytime we offer education within our home, and we reference this as part of our best practice guideline growth within the project. So, you know, once our team starts to see there's the benefit to, of course, their own knowledge and the outcomes of the resident, everybody just gets on board. It becomes part of the norm. And that's that is the culture here at our facility when we introduce new projects, especially something like the BPSO.
And especially our PSWs, because they're our first eyes, you know, and we are empowering them a lot, you know. So whenever they're coming, I'm telling them that you're our champions. You have to come to report if you see anything. Even the housekeeper, you know, all of us, like all interprofessional approach is extremely important in this project.
Definitely. I really appreciate the interprofessional engagement, the frontline engagement, and, you know, for example, giving the PSWs, you know, iPads for documentation, because that assessment is first line when it comes to being able to engage with the patient and families in regard to the pain, whether it's been optimized or not. And thank you so much for that. I do have a question from Lori. She says, can you please provide your PSW to resident ratio and elaborate on how you got the staff to buy into the hourly rounds when they already pulled in many different directions under the current staffing?
So our ratio is we have 9 residents per 1 PSW. And yes, you're correct. Everyone in long-term care wears many hats and is pulled in many directions. But again, when we are able to explain the purpose and the desired outcome of a project and how it already will intertwine with the current tasks of the day, our PSWs are able to jump on board. You know, it's already capturing things that they're looking at and reporting on, you know, on an hourly basis at times. So when our team sees the purpose and what the outcome, the positive outcome it will have, we really don't have any pushback on that.
Okay, excellent. Thank you. And in regard to the purposeful rounding, you show very impressive outcomes when it comes to pain and use of opioids and other non-pharmacological approaches. How do you go about sharing back that data as a means of motivation with staff, patients, families, the public?
So we have boards, you know, on each individual floor, we will have boards with all our graphs. We will share the information. We will provide kudos to our, you know, staff and show to them, look how well we are doing with our pain management and assessment. We have binders. We have champions who are quality indicator champions. We have MDS backup people who are working on the data. RIMDS coordinator with Sky High, you know, that we are working and seeing, you know, all the outcome scales or the pain management for quality indicators. So, you know, on an ongoing basis, we're working also with packets with physicians, and we are providing the data how we're doing. They're working very strongly with pharmacists. So pharmacists kind of working hand in hand. They're providing report to me, for example, for pain, who is on scheduled medication, who are on PRN medication, how many times did we give PRN? And maybe we should now change it to scheduled medication if it's done quite often, if we are administering quite often PRN, so we're changing to schedule. They're providing me information with antipsychotic medication with no diagnosis. Then I can assess and taper the resident very slowly if they don't need it. So because we trying to get off as much as we can our resident from antipsychotic drugs.
And just to add, Clara and I and many of our interprofessional team members participate in a pain committee on a quarterly basis. And as she also mentioned, these statistics from pharmacy are also reported during our PAC meetings. So this data is not disseminated to everyone on a daily basis because of really good communication in our home. Yes, but you know, it's also formally presented in these formats.
That's fantastic. I really like the extent of the communication and that the data is used and the data that is collected is meaningful to be able to further inform the program, both at system level as well as for individual patients. So thank you for that. Just a follow up in terms of the outcomes, with the purpose surrounding, you also assess, for example, positioning and falls, to reduce the risk of falls, etc. Have you seen any collateral changes in regard to other outcomes as a result of better management of pain?
Management of pain, because of early rounding, we're turning in position much more, often. We are trying to prevent falls, again, skin integrity with all of this. So all the quality indicators, we may minimizing restraints to minimum, and because we're checking the resident on an hourly basis. So everything is working kind of in collaboration. One is going after another, and for example, hydration. When we're coming to see the resident, we're providing fluids as well and assessing for hydration. So everything is going together, one after another.
Which is again
and
why
toileting program, for example.
Which is again the holistic interprofessional approach. That's the stance that we take in our home so that, all of those needs are met for the residents.
Fantastic.
Working with physiotherapy and occupational therapy, we are lucky that we have here OTs and PTs who, for example, if the PSW is coming, but it's a little bit swollen wrist, maybe it's arthritis, maybe, So we are assessing the physiotherapy. We will be able to come to assess the patient for range of motion, for mobility, for flexion, and then we can provide some massages or non-pharmacological treatment as well as pharmacological.
Wow. That's amazing. Thank you. And, there's comments here about the work that you're doing is really impressive. And another comment that I'm a PSW and I'm using purposeful engagement interventions to our residents, and it's amazing outcome in their home. That is the 4 Ps. And checking for 4 Ps along with intentional rounding is what Samuel is also doing. There is another question here. Resident responsive behavior incidents. Have you tracked the direct correlation? Is there a decrease?
Well, okay, so our facility is very complex. We have a very complex population. So, and there are a lot of responsive behaviors present in, I would say, probably the majority of our residents. So anytime there's a change, like from their baseline with behavior, we're looking at all the possible factors. So is there infection going on? Is there an pain going on? What could be the source? So we meet as an interprofessional team formally 3 times a week in the morning for our morning meeting, our risk management meeting, and anything out of the ordinary is discussed for each, any resident at that time at an interprofessional level. So all possible interventions are used and explored at that time. So yes, I would say in a general sense, there is a reduction in resident responsive behaviors when we're able to successfully identify, the trigger or the source of that. And sometimes it is pain. So again, just meeting as a team and really looking at that resident individually to determine what would be the best way to support them.
And responsive behavior, for sure, we have to rule out, first of all, delirium. So as a nurse practitioner, I'm able to do my rounds and to see if it's delirium due to the physical condition like urinary tract infection or any other pain management. We can also refer to BSO. We have BSOs that we are working very strongly together. Psychiatric, we are working with TRI, responsive behavior as neurology. We were able to transfer the resident to Baker's for full assessment for responsive behavior when we are not able to treat them and need a little bit more help. And now next week, we have one of the residents going to TRI for behavioral neurology to assess him.
Okay, thank you. Thank you so much. And I suppose it looks like not everyone knows what the intentional rounding or the 4Ps is. Do you mind clarifying what the 4Ps are? Just because the purposeful rounding seems to be a very impactful intervention and part of your pain management process.
So it's pain, positioning, toileting, it's going for party P, toileting, and personal belonging. Like, for example, they want a box of Kleenex that's close to them, water or anything like this, so we can provide them.
Okay, excellent. Well, thank you so much. Again, it looks like that we have a couple minutes before we close, and just want to thank Clara and Carrie for the excellent presentation and for the engaging questions and answers that we have that took place today. Just wanted to let you know that this is part of a mini series of a focus on pain. So next month, we're going to be talking about a holistic approach to pain in long-term care. And this one is going to be done by the Region of Peel, the Sheridan Villa Long-Term Care Center. And as you see that pain is a very big topic and an area of focus in long-term care homes, and it is a universal experience regardless of what healthcare sector that you're in. And if you have any questions about this webinar or future webinars, please feel free to email Andrea at astubbs@rnao.ca, and you will also be receiving an evaluation survey. So please fill that out. The presenters today would love to be able to hear from you as to how the presentation went, as well as what future topics you would like to see for the Champions Network. So without further ado, thank you very much, everyone, for participating, and thank you to the presenters for your excellent presentation. I'm going to say goodbye for now and have a great afternoon.